I won't move this. All right, everybody. If I could get your attention, please, we'll get started. Okay. So everyone's got their sandwiches, their lunch. Perfect. So I have the pleasure today of introducing Dr. Gill. So Dr. Gill is one of our addiction medicine fellows with the BC Centre on Substance Use, and is actually also concurrently doing his psychiatry residency at the University of British Columbia at this time, so doing both at the same time. So he spent time both at the University of Manitoba, completing both his Bachelor's of Science and MD degree at that time. He was excited to return home to BC for his residency and completed his intern year here at St. Paul's when he first came back. In terms of today's presentation, Dr. Gill's interest in pathological gambling actually started when he worked at a casino in Winnipeg, and he will share more about that experience with you. Other interests of Dr. Gill's include harm reduction, addiction peer support groups, and drug policies. And just before we get started with our presentation, I just want to put it out there that we still have applications open for our research fellowship in the addiction medicine fellowship and also our social work fellowship. So if anybody's interested, there are some pamphlets at the front. So please feel free to grab them on your way out today. So hand it over to Dr. Gill.
Thanks for that warm introduction, and thank you for coming out. For my ego, I'll assume it has nothing to do with the free lunch. So I'd like to begin by respectfully acknowledging that most of us are humble guests here on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and I appreciate the opportunity to present here today before all of you. I do have two disclosures to make. Firstly, I was previously employed by Canadians, which is a large hospitality company based in Manitoba. Initially, I worked as a bartender, but also as a cashier at one of their casinos. And later I did some consultant work when they opened up a new bar. I am mitigating this bias by one, disclosing it, and two, I don't have any current relationship or plans for a future relationship with Canadians or any other casino for that matter. All of this was before I became a doctor, and as you can imagine, some of my interest in addiction comes from the times I spent working in bars and casinos. I almost think of this talk as bringing awareness and a form of repentance for myself for my previous sins. Secondly, I own stocks of Isracan Biosciences. This is a cannabis company based in Israel, but it trades on the Canadian Stock Exchange as IPOT. I'm making this disclosure for thoroughness only. My talk doesn't mention cannabis, and I'm no way promoting the use of cannabis here today. The objectives for today include a comprehensive overview of gambling disorder, including the history and current impacts. I will also be reviewing the diagnostic history and summarizing the evidence for screening tools and treatment options for gambling disorder. I had initially planned to spend more time talking about other behavioral addictions, but as the talk came together, I had to narrow it down because of time. I will, however, quickly review other entities that have been labeled as behavioral addictions. So first things first, what is gambling? Gambling is the placing of a wager or bet on an uncertain outcome. Gambling can include games of skill, chance, or a combination of both. I think it would be apparent that games at a casino, lottery tickets, and even sports betting are gambling. But what about buying insurance? Buying insurance can seem similar in that you're putting money down and will get a payout if an uncertain outcome occurs. But it is not considered gambling because most people buying insurance are not hoping for a payout. Most people are hoping their house burns down for the cash. And the insurance companies also are hoping for the same outcome. Both the insurer and the purchaser are aligned in that case. Buying insurance is simply a way of reducing risk by spreading it over a deep pool of people. What about stock? Is that gambling? Yeah, buying high-risk stocks can be considered a form of gambling, and people with gambling disorder can have this be a part of their condition. Historically, gaming has been used to refer to legal activities, and gambling was used to describe illegal activities. However, this distinction isn't used much now, and the Diagnostic Statistical Manual, the DSM, refers to gambling as including both legal and illegal activities. So I'll be using the term in the same way today, capturing both forms. All right, let's get into the history of gambling, which dates back further than written history. This obviously makes it difficult to know things in great detail, and there'll be different historians with different views. Therefore, I've chosen just to highlight some of the more known and interesting facts. The oldest historical items related to gambling are wooden dice, found in coffins believed to be over 6,000 years old. It is believed that the earliest forms of games of chance were used to predict the future. Dice or even shells and sticks were thrown and then subsequently read to learn what the future held. First Nation communities in Canada had their own forms of gambling before contact with Europeans. They too had superstitions around predicting the future. The first written mention of playing cards dates back to the 9th century. However, the standard 52 card deck, which is probably most familiar to us, that includes spades, hearts, diamonds, and clubs, originated in France in 1480. It is believed that the 52 cards were chosen to represent the 52 weeks, and the 4 suits represent the seasons. During the Second World War, Americans hid secret maps in playing cards that would only become visible once the cards were moistened. This was something they kept on their person in case they became prisoners of war and needed a stealth map. The first casino opened in 1638 in Venice, Italy. The first slot machine was used in 1895, with video slot machines debuting in 1976. Canada's first commercial casino opened in Winnipeg 30 years ago. That's not where I worked. So what are the stakes? Apparently pretty high. Around the world, people collectively lost $400 billion US dollars due to gambling in 2016. The burden related to gambling, which is things such as financial impact, damage to relationships and health, emotional and psychological distress, and negative impact on work and education, are greater than the collective impact of major depressive disorder. This burden is disproportionately carried by disadvantaged and marginalized populations. Youth and women are also high-risk populations. Gambling disorder is rarely talked about, but there is an unprecedented growth occurring due largely to the rapid development of the online gambling market. Here's a graph depicting annual gambling losses in 2016. The values are per billions in US dollars. First place is the US with over $100 billion lost collectively. China is second with over $60 billion lost. Canada, if you look down the list, finished in 7th with over $10 billion. It's important to note that these numbers are absolute values, so they don't factor in the population size of the country. If we calculate numbers based on per capita, Australia, which is 5th on this list, ends up in 1st place with $1,300 lost per adult in 2016. Per capita, Canada moves up to 4th with a loss of $570 per adult. Interestingly, almost all Islamic countries ban all forms of gambling, as does North Korea, Japan, and many more. So what are the gambling habits of Canadians, you may be asking? 75% of Canadians gambled last year. Men more commonly choose online betting and equally prefer table games such as poker and sports betting. Women are more likely to choose games of complete chance, such as bingo. Other popular games amongst Canadians are slots and office pools, which are also a form of gambling. The largest gambling prize claimed by a single person in Canada was the 649 jackpot for $64 million, which was won in 2015. Now, I don't want to promote the lottery, so the sobering reality is the odds of matching 6 out of 6 numbers on the Lotto 649 is 1 in 14 million. This is a reason why lotteries can be so appealing, though. The jackpots can be astronomical. The biggest jackpot in the world was won in South Carolina 1 year ago. A single winner won the $1.5 billion jackpot, and after opting for the lump sum payment, walked away with $878 million. That's nearly $1 billion. Here I've posted the epidemiological stats from DSM-5. The past year prevalence of gambling disorder is estimated to be 0.2 to 0.3%. The numbers for people who have problematic gambling but do not meet full diagnostic criteria is estimated to be around 3 to 5%. Lifetime prevalence is believed to be about 1%, although there is some evidence that the prevalence is increasing since the release of DSM-5, which was in 2013. Unfortunately, less than 10% of those with gambling disorder receive any form of treatment. There are a variety of reasons for this, and I'll get into that later. There is a sex bias, with males being 2 to 3 times more likely to have gambling disorder than females. There are two populations who are at increased risk for more severe consequences or course of illness. Young adults being one group who have significantly higher rates, and females who display a telescoping course of illness. Telescoping is a term used in other addictive disorders as well, such as opiate disorder and cannabis use disorder. It refers to the accelerated course of illness seen in women. They go through the steps of initiation, so the first time gambling, to developing gambling disorder and entering treatment faster than men, and in general, enter treatment with a more severe form of the condition. So this also means that there's less time to intervene in women between the time they're gambling but it's not problematic to the time they have a diagnosable gambling disorder. Gambling disorder rarely occurs alone without any other psychiatric comorbidity. Some of these numbers are staggering. 76% of those diagnosed with gambling disorder will have a major depressive episode at some point in their lives, with recurrent episodes likely to occur in almost 28% of the people. Substance use disorders occur in 50% of people with gambling disorder, and that increases to 63% comorbidity for those receiving treatment for gambling disorder. So the clinicians in this room are likely seeing many patients with substance use disorders. If we flip the numbers, 10 to 18% of people with substance use disorders have gambling disorder. That actually may be a surprising reality. Looking further down the list, you will see increased rates of antisocial personality disorder, schizophrenia, and specific phobias. I really want to highlight this. The numbers for suicide are alarming. These are based on a study done in Sweden, which was published in 2018. Compared to the general population of adults in Sweden, those with gambling disorder had a 15 times increased risk to die by suicide. That risk was even higher in youth and middle-aged adults. 20% of patients with gambling disorder reported attempting suicide, and that number is not unique to Sweden. One out of 5 was showing up in other resources I looked at as well. 1 in 2 have suicidal ideation. Clearly, death by suicide is a very complex issue, and it isn't easy to figure out exactly how much gambling disorder plays a role in someone who attempts or completes suicide. And you wonder if there's an underlying mood disorder. However, in this study, they calculated that the risk of death by suicide would increase in patients who had major depressive disorder if they were to subsequently develop gambling disorder. So I really like this quote by Schaefer. Addiction is a relationship between a vulnerable person and an object of addiction. And like all relationships, the unhealthy connection between person and object does not occur in a vacuum. Risk factors for developing at-risk or disordered gambling include initiating gambling before the age of 18, antisocial personality structure or hanging out with antisocial peers. And to clarify, that antisocial means not following the social norms or the rules of society. Thrill-seeking personality. And residency near a casino has also been cited as increasing one's risk. Family history is considered a significant risk factor. Just like substance use disorders, genetics account for about 50% of the risk in developing a gambling disorder. The addiction syndrome is conceptualized here in a diagram by Schaefer. It shows risk factors on the left, which include neurological and biological factors, which will include your genetic makeup, as mentioned. Next, it describes the social and psychological factors, which in gambling disorder can be your peer groups, underdeveloped coping mechanisms. The more risk factors you have, the greater your underlying vulnerability. Now you need to have exposure in addition to vulnerability to start an addictive behavior. The middle section depicts how the behavior is reinforced from initiation to repetition of behavior. Both positive reinforcement through improving mood and negative reinforcement impact this stage. Finally, on the right, in the person with addictions, this manifests in many different forms, but the negative consequences between addictions can be similar. There may be reasons why some people gravitate towards certain addictions, but a large portion of people can easily move between different substance use disorders and even addictive behaviors such as pathological gambling. The dopamine reward pathway is thought to be heavily involved in the development of all substance use disorders and gambling disorder. So does anyone here ever buy a lottery ticket or like a scratch off? Oh, just me? Okay. So you wouldn't buy the lottery if you didn't think you could win. But those with gambling disorder have significant cognitive distortions that impair their ability to be informed about their risks while gambling. Superstitions are variable, like from articles of clothing to movement patterns, knocking, or lucky objects. And some professional athletes do have superstitions as well, but this looks very different in pathological gambling. Overconfidence occurs as well, which can lead to underestimating the risk and gambling more than a comfortable amount because you believe you will win and can't possibly lose. Another cognitive distortion is the sense or illusion of control, thinking you can influence the outcome of a game of chance, which simply isn't possible. Memory biases are occurring when you overestimate your previous winnings and are more prone to forget about your losses. Some players may wrongly assume that if they've lost a couple of hands in a row in something like a game of blackjack, that they should bet more because now they're due to win. This is distorted thinking because even though the odds of losing 5 hands in a row are low, every hand is an independent outcome. And losing the previous 4 hands in no way makes it more likely that you'll win the 5th one. I know I started by saying gambling dates back thousands of years, but gambling as a diagnosis dates back only a few decades to 1980, when pathological gambling was described in DSM-3. Prior to this, gambling was more often mentioned in legal arenas due to the many illegal forms of gambling. Pathological gambling, or gambling disorder, as has come to be known since the release of DSM-5, has an interesting history which I wish to highlight. Before doing that, I want to point out the importance of DSM and universal diagnostic criteria. Consistent, reliable diagnoses are needed for research to compare different treatment options, help determine risk factors and causes for specific disorders, and calculate things such as incidence and prevalence. Without universal diagnostic criteria, research results become much less generalizable or useful. This is a copy of DSM-3 listing the diagnostic criteria for pathological gambling. Originally, pathological gambling was included under the impulse control disorders. There are 3 diagnostic criterion, and they all needed to be satisfied. For criterion B, a minimum of 3 out of 7 items needed to be positive. None of these criteria were based on research or externally validated. They were based mostly on the clinical expertise of one doctor who was chosen to write that section of the DSM. Although Stacey did consult some of his colleagues, so a little more robust. Criterion A was chronically and progressively unable to resist impulse to gamble. And then 5 out of 7 items in criterion B were related to money and finances. That heavy focus on finances received negative feedback. Interestingly, antisocial personality disorder was an exclusion criterion. In DSM-4, there was a major change in diagnostic criteria. This reflects the change in thinking at that time, where it was beginning to be seen as more of an addiction. However, it was still categorized under impulse control disorders. With DSM-5 being relatively new, published only 6 years ago, it's important to know that most of the recent research available uses DSM-4 diagnostic criteria. However, there isn't much difference between DSM-4 and DSM-5. Item number 8 has committed illegal acts to finance gambling, which was added in DSM-4, was promptly removed in DSM-5. And as a result, you needed 5 out of 10 criteria in DSM-4, and DSM-5 only now states 4 out of 9. The rest of the criteria have remained the same. This is the DSM-5 criteria. The biggest change made was renaming it gambling disorder and moving it into the substance use or substance related and addictive disorders chapter. The timeline has also changed from a lifetime to a discrete 12-month period. The lifetime parameter in DSM-4 was because at that time it was thought to be a chronic lifetime affliction. But now it's better conceptualized as an illness that can be in remission. You may notice that the criteria match up very closely with the diagnostic criteria for substance use disorders, and I'll highlight those similarities now. So number 1, gambles with increasing amounts of money to achieve the desired excitement. This is comparable to the tolerance criteria, a need for markedly increased amounts of substance to reach intoxication or desired effects. Number 2, restless or irritable when attempting to cut down or stop gambling. That sounds a lot like withdrawal. Dysphoria when cutting down or stopping use of a substance. Number 3, repeated unsuccessful attempts to cut down or stop. This is pretty similarly worded in substance use disorders as well, with the persistent desire or unsuccessful efforts to cut down or control substance use. Number 4, preoccupation with gambling, persistent thoughts of previous gambling experiences, planning the next venture, and thinking of ways to get money for gambling. Although the word craving is not used in this description, it sure does sound a lot like drug cravings to me, which is described as a strong desire to use substances. Number 8, has jeopardized or lost significant relationship, job, or educational or career opportunities to gambling. This is describing the functional impacts of gambling, which in substance use disorders is described over a few different criteria, but also points to the impacts on social, interpersonal, educational, and occupational domains. The criteria not highlighted do not correlate with the remaining diagnostic criteria for substance use disorders. Number 5, often gambles when feeling distress. Number 6, after losing money, often returns another day to get even or chase losses. Number 7, lies to conceal extent of involvement with gambling. And then number 9, relies on others to provide money to relieve desperate financial situations caused by gambling. Now, I would argue aside from chases losses, all the other criteria can be seen in substance use disorders as well. Uses when distressed, hides extent of use, needs financial help from others, or even engages in illegal activity to pay for substances. Maybe somewhat surprisingly is that there's no criteria on the amount of money spent or lost. Someone losing $1,000 per month doesn't automatically have a more severe illness than someone losing only $100 per month. If we take just a step back for a second, substance use disorders are often conceptualized using the 4 C's: loss of control, inability to cut down, cravings or preoccupation, and then using despite negative consequences. So hopefully I've been able to highlight, pun intended, those same qualities exist in gambling disorder. Now, gambling disorder does have overlap with other so-called behavioral addictions. This becomes important as there are research studies where treatments of behavioral addictions are lumped together. However, some of the above do have more diagnostic controversies. Internet gaming disorders listed in the DSM in a chapter for further review, and thus it is not a true diagnostic entity yet. There is emerging evidence about disordered internet use, but there's a lack of information around whether internet gaming, general problematic internet use, and pornography addictions would all be the same disorder or distinct ones. This still needs to be teased out, and evidently much more attention is currently being paid to problematic internet use, especially in youth. Hypersexuality or compulsive sexual behavior was rejected as a diagnostic entity because the DSM working group felt they'd be required to define a normative amount of sex in order to delineate hypersexuality, and they didn't want to do that. That being said, many patients will describe their hypersexuality as an addiction and a problem for them. And in media, there's often celebrities highlighted who claim to have that and seeking treatment. So it is a topic discussed. Kleptomania is fairly interesting and has a longer history. Kleptomania was first described in the 19th century by Swiss physician Dr. Matthay as a unique madness characterized by the tendency to steal without motive or necessity. Compulsive buying disorder is an ICD-10, but not DSM, and is characterized by obsessive thoughts to shop with pleasure during the researching and browsing for items, but significant guilt and dysphoria shortly after the purchase is made, and then the cycle repeats. So screening is very important when it comes to gambling disorder. Unlike substance use disorders, there is no urine screen or lab test for gambling disorder. You can't, there aren't any physical exam signs either. You can't smell gambling disorder on someone's breath or check their pupils for poker intoxication. South Oaks Gambling Screen is a 20-item questionnaire that can be self-administered. It was created in 1987 by Lessier and Bloom, and it's been validated in at least 25 different languages around the world. And it's the one most often used in research. But over the years, it has faced its share of criticisms. The time it was created was during DSM-3. And like we said, the criteria for pathological gambling was based on the clinical experience of one doctor without any validated diagnostic criteria. So therefore, South Oaks Gambling Screen shares some of the same limitations. The questions are not well aligned with the current DSM-5 criteria. And 9 of the items deal exclusively with borrowing money to gamble. Currently, a cutoff score of 5 is used, meaning a score of 5 or higher indicates the person is likely a pathological gambler. It's important to keep in mind that a screen tool is different than a diagnostic tool, and a positive score on a screen should really be an indication to do a diagnostic interview or further inquiry. That being said, there's still many quasi-experiential studies done where the South Oaks Gambling Screen is used as a diagnostic tool. Goody and Company did a study where they evaluated the South Oaks Gambling Screen, and they actually recommended increasing the cutoff from 5 to 8 for use as a screening tool, and the cutoff of 12 to estimate prevalence in studies. This is to help with the high false positive rates. The Gamblers Anonymous screen has not been validated, but it too is a 20-item questionnaire with a cutoff of with a cutoff of 7 for compulsive gamblers. The Massachusetts Gambling Screen was developed in adolescents, and there are actually some other screens aimed for adolescents as well, but this one seems to be the most popular. The Canadian Problem Gambling Index was created in 2001 after a 3-year process. It's been validated against South Oaks Gambling Screen as well as the DSM-4 criteria. It includes many items that are identical to both of those instruments. So just to show how simple a screen can be, take 2 minutes and calculate a score for yourself. All right, hopefully that was enough time for you to score yourselves. So here's the scoring chart that's also included. As you can see, the scores are stratified into 4 categories. At the bottom, a non-problem gambler is defined by a score of 0. Low-risk gambler is indicated by a score of 1 or 2. And then moderate-risk gamblers are those that score 3 to 7 inclusive. At the very top is the high-risk group, those scoring 8 or higher. So now if you felt that last screen took an excruciating long amount of time, you're in luck. The simplest screen is the lie bet screen, and it's simply 2 questions. Have you ever had to lie to people important to you about how much you gamble? Or have you ever felt the need to bet more and more money? An answer of yes to either question is considered a positive screen and indicates likely pathological gambling. Now that seems like it's almost too simple. However, a study was done to validate the screen by Johnson and Hamer. They recruited subjects from Gamblers Anonymous who had scored at least 13 out of 20 on the Gamblers Anonymous screening tool. And they also recruited healthy controls who had never had problems with gambling. The table shows the impressive results. In total, 362 people were included. There were 190 true positives and only 1 false negative. In the middle row, you'll see there was 16 false positives and 155 true negatives. Doing the math yields some impressive numbers, including a 99% sensitivity, 91% specificity, positive predictive value of 92%, and negative predictive value of 99%. Of course, there's some limitations, with the biggest being the population that was selected for this study. The problematic gamblers were in treatment and scoring 13 or greater out of 20 on the Gamblers Anonymous screen, which actually has a cutoff of 7. So the population they used actually had a much more severe form of addiction. So this isn't as impressive as it may seem on first glance. But if you only have 2 seconds to screen, that seems like a decent approach. So research and treatment options are still in the relatively early stages. There are no treatment guidelines to easily reference to inform clinical decision making. That being said, it's not all bleak. There are some promising early results out there. What complicates research is that the neurobiology and pathophysiology of gambling disorder are not fully understood, and it leaves ambiguity as to what types of medication research efforts should be focused on. Treatment can be inpatient or outpatient, groups or individualized, including combinations of non-pharmacological and pharmacological therapies, and it can include treatment of a comorbid psychiatric or addiction disorder. So number one, behavioral therapy works on the premise that gambling is a learned behavior. And like all learned behaviors, it can be unlearned. To better understand the behavior, antecedents, the situation and mood before gambling, the details during periods of gambling, and the consequences will be examined for each patient. These emotions, behaviors, and consequences can then be used in imaginal or in vivo behavioral experiments to extinguish gambling urges. So the thought is, pairing the thoughts of negative consequences with cues to gamble will induce a change in thinking where gambling becomes associated with negative moods and consequences and subsequently becomes less and less appealing. Skills are also developed, such as assertiveness, to also combat problematic gambling. There is no CBT or one CBT manual that has emerged as a clear favorite for gambling disorder. CBT in general is highly adaptable to the needs of the individual patient. There have been studies in both group and individual settings, with both settings showing promise. CBT targets distortions in thinking, which I described earlier. It challenges the ideas patients have around overestimating their likelihood of winning despite statistical evidence, questions the ideas patients have around sense of control over outcomes of chance, as well as memory biases related to remembering wins and forgetting losses. CBT also looks at relapse prevention, problem-solving skills, and relaxation techniques, and includes behavioral therapy techniques as well. There are no set number of sessions needed to complete the treatment, but generally CBT lasts 1 to 2 hours and about 8 to 12 sessions. The largest study I could find had 71 patients with gambling disorder receiving CBT, with a control group made up of people on the waiting list. The treatment group received 10 sessions, and at the end of treatment, 88% of patients who received treatment and 20% of the controls on the waiting list were in remission. At a 2-year follow-up, 68% of those who had completed treatment were still in remission. There's no number for the control group because they were on the waiting list, and at some point in those 2 years, they hopefully got some form of treatment. The most glaring limitation in this study was that only 47% of people completed, there was a 47% dropout rate. And the reported numbers are for those who completed treatment. So motivational interviewing can sometimes be a covert treatment, as it's less formal, and as a result, it's less likely to be rejected. 50% of referrals by primary care doctors to addiction specialists for gambling disorder go unattended by patients. In motivational interviewing, patients' own strengths are tapped into to activate change behaviors. There's multiple small studies with positive results. In these studies, motivational interviewing is combined with bibliographic resources. The largest study to date included 150 patients with gambling disorder, and it compared motivational interviewing with brief intervention to CBT. Both groups showed significant improvement that maintained at the 12-month follow-up date. Both groups showed about equal results. There have been some more recent small studies where MI with brief intervention is being combined with CBT, and that's showing promise as well. Gamblers Anonymous, which was founded in 1957, based on the same principles as Alcoholics Anonymous, where there are both open and closed meetings. The steps are more or less the same, although the sponsors in Gamblers Anonymous will meet and also help you form a financial plan to repay debts if those occur. Gamblers Anonymous groups have not undergone much research scrutiny, and their effectiveness is unclear. Having to acknowledge a greater power can be a hang-up for some, so this treatment may not appeal to everyone. Voluntary self-exclusion programs exist in many forms. I will detail the program that's offered through the BC Lottery Corporation. So anyone can sign themselves up, and this will prohibit you from accessing casinos, bingo halls, and then online gambling at the Play Now website. You have to pick a time period between 6 months and 3 years, but once that time has been set, there's no way to change it or cancel it. If a person manages to play, so if you get into a casino without being recognized and you win money, you can still have your winnings taken away if it later becomes revealed that you're in the self-exclusion program. If you sneak in and play and lose a bunch of money, well, you don't get that back. There's no controlled studies testing the efficacy of this strategy, but it may be a valuable tool for certain people. And then abstinence can be improved if you combine this with other complementary therapies. The Canadian Centre on Substance Use and Addiction has started the task of creating and publishing Canada's first national lower risk gambling guidelines. This is similar in concept to Canada's low risk alcohol drinking guidelines. The process to make these guidelines started in 2016. So it should be done any day now. And this was because they recognized a significant public health issue without any evidence-based guidelines to inform individuals to make responsible choices and minimize their gambling-related risks and harms. So currently, the only national recommendations that exist are for a parallel approach that has been successful for decreasing tobacco use. So this applied to gambling, it would look like decreasing availability, which is pretty hard considering the online market, banning advertising for gambling, keeping lottery tickets out of sight, like what's happened to cigarette packs at checkouts, and finally consider a ban on building new casinos. Because as we know, your risk increases based on your proximity to a casino. There are also a variety of policies around the world which are targeted directly towards reducing gambling harms. Some of them are like slowing down game speed. So if you're at a slot machine, you can't just keep hitting the button every second. It's built in to have a bit of a delay. There's also mandatory breaks in certain places, maximum bets, and also reducing the frequency of near misses. So the automatized slot machines can have it seem like you just had the jackpot if you had just hit it, a second earlier or a fraction of a second later, which entices people to play more and more. But there is a kind of maximum frequency at which the slot machine can read that for you. So there are no medications approved to treat gambling disorder in Canada, but many have been tried as an off-label use. So the medications can modulate the reward pathway by altering glutamate, serotonin, dopamine, and the endogenous opioid pathways. There are some medications to avoid. The FDA had a black box warning on aripiprazole, cautioning that the drug can cause a side effect of compulsive or uncontrollable urges to gamble, binge eat, shop, or have sex. The increase in impulsive behavior was originally listed as a side effect, but after many lawsuits came forward from patients claiming they had gambled away their life savings, the FDA thought it'd be better to make the side effect more prominent with a black box warning. Another note of caution, pro-dopamine medications used in Parkinson's have been cited for worsening impulse control, including gambling. So currently there are limited studies with antidepressants, mostly using SSRIs. The results have been mixed, with some positive results, but some equal to placebo. There's better evidence for antidepressants to be helpful in the case of comorbid depressive disorders. Citalopram, fluoxetine, and bupropion have shown benefit in small trials, even in the absence of a mood disorder. There is lack of long-term follow-up, and given the relapse and remitting nature of addiction disorders, this is an important piece of information that is still missing. Lithium has some case report evidence in helping reduce severity of gambling disorder in people with bipolar illness. Whether it would work in the absence of bipolar disorder remains to be seen. N-acetylcysteine, NAC, is available over the counter and may be an option for those firmly against prescription medications. It's a derivative of the essential amino acid cysteine and has been marketed to save or to have a whole host of benefits and treatment potential. Some people take it as a supplement for its perceived antioxidant benefits. It has been shown to be superior to placebo in preliminary trials and then well tolerated up to doses of 1,800 milligrams. Opioid antagonists have the strongest empirical evidence out of all the pharmacotherapies. Both naltrexone and namphene, both mu-opioid receptor antagonists, have been studied. However, namphene is no longer available. There are 4 placebo-controlled studies for naltrexone showing significant benefit over placebo. There have been reported issues of tolerability at higher doses, but the more recent studies are done with naltrexone at 25 to 50 milligrams, and even in those studies, it shows effects better than placebo. An interesting association has come out of the studies in that those with personal or family history of alcohol use disorder respond better to naltrexone. This may indicate a closely linked pathway between these two disorders. So here's proposed pharmacotherapy algorithm by Bollock and Potenza. They use PG for pathological gambling. So starting at the top, you have a patient A with gambling disorder. And if they're completely against any medications, well, then your options are limited to NAC. However, if they're willing to consider medications, then it's important to know their psychiatric history. If there's no co-occurring psychiatric illness, then consider starting naltrexone. If the psychiatric history is positive for substance use disorder, or if there's a positive family history of alcohol use disorder, then once again, consider naltrexone. If there are ongoing opiate use, then naltrexone may not be appropriate. If you have a patient with a comorbid mood disorder or anxiety disorder, consider an SSRI, unless they have bipolar, in which case consider a mood stabilizer. If your patient with gambling disorder has a positive psych history that does not include mood disorder or anxiety disorder, then once again, consider naltrexone. So as you can see, naltrexone is preferred in 3 out of 6 of these scenarios. SSRIs are suggested if the patient has depression or anxiety, mood stabilizers if the patient has bipolar, and then NAC if the patient is not open to trying any medications. All other scenarios, try naltrexone. So for the clinicians in the room, I would recommend having a higher suspicion of gambling disorder, especially for those with presenting with substance use disorders. Also get to know your patient's psychiatric history, as that can help in selecting treatment options. Inform patients about their treatment options. Currently, less than 10% of people with gambling disorder are receiving treatment. The Canadian Low Risk Gambling guidelines should be out next year, and it will include recommendations on treatments, but I'm just not sure how detailed they'll be. The take-home messages I want you to leave with from this talk are: gambling disorder is a significant condition with a large burden of disease. The impacts on finances, relationships, and functioning are devastating. The risk of death by suicide is staggering. Unfortunately, there are no treatment guidelines available due to the lack of robust research, but given the impacts of this illness, it should still be uncovered and diagnosed, and treatment plans should be made based on what evidence is available. Patients are both reluctant to accept help and unaware of what treatments exist. Further studies are needed and they are happening, so keep your eyes peeled. All right, thank you for listening. Any comments? Yes.
I have a question about treatment options here in Canada.
Yeah.
We have a universal public health care system, but I was wondering for someone with a gambling addiction, most of the time they will realize that they are in a big problem when they've lost a lot of money, so they could probably not pay for treatment. So what sort of options do they have in our healthcare system?
In terms of getting funding for something like naltrexone, or?
I mean, whatever treatment options.
Right, so if we're thinking of non-pharmacotherapy, there are services that are not private pay. So you can refer to CBT, other psychotherapies, and they will be covered. If you have money, private pay is usually a lot faster. The wait list can be very long for a lot of the mental health services. Yeah, was that more or less your question? Yes.
I can just add to that the information you have on the screen right now, the problematic and responsible and problem gambling program. You pay for private one-to-one therapy for residents of BC for gambling, for gaming addiction, etc. So you can get connected. Yeah.
It's good to know. Yes.
I'm curious to know if there's an overlap of gambling disorder and ADHD, and if there is there any role for using the dexamphetamine for the compulsions like you do with binge eating?
Yeah, that's a good question. Nothing that I saw with ADHD that had that comorbidity. I put up the ones that I found. It has been kind of lumped in with other impulse control disorders in the past, but it's moving away from that. So maybe it was conceptualized better that way before, but it doesn't seem to actually hold up. Yes.
I'm concerned about video gaming and fun. I've seen a lot of games today incorporating gambling type of behavior or reward in games. I wonder if there's much research going on about this younger generation and these video games of media creating gambling behavior earlier in
Yeah, that's an interesting thought. Internet gaming in general is being studied now, and really not much is known about it because it's relatively new, but I'm sure the developers are very savvy and can find ways to make anything more addicting. And a lot of the games do have the option to make purchases as well. So I'm sure all that ties together, but what the evidence shows, I'm not sure. I think it's just too early. That's a good point. Cool, I think we're done.